Welcome. Today's Fern educational opportunity discusses the Dizzy Emergency Department patient and the GRACE 3 guidelines which come to the rescue of the emergency clinician. My name is Edward Sloan. I'm an emergency physician from Chicago. I'm Professor Emeritus in the Department of Emergency Medicine at the University of Illinois at Chicago. I'm Medical Director for the Physician Assistant Studies Program at Dominican University, and I'm Medical Director for New Rose Healthcare Management, which helps the staff an emergency department in a safety net hospital on the south side of Chicago. Thank you to the EIM group, the group that initially supported my presentation of this information in December of 2022. I have no financial conflicts. I'm the Fern President and Board Chair. Fern has educated emergency clinicians for 2 decades in how to optimize the care of patients with neurological emergencies and injuries. We now will consider the GRACE 3 recommendations regarding the spontaneous episodic vestibular syndrome patient. What is the GRACE 3 recommendation for clinically evaluating spontaneous episodic vertigo syndrome vertigo patients? Clinicians should perform a history and physical exam with emphasis on cranial nerves, visual fields, eye movements, limb coordination, and gait assessment to distinguish between a central cause, such as a TIA or transient ischemic attack, and a peripheral cause such as vestibular migraine or Meniere's disease diagnoses. This is actually an ungraded good practice statement that says, do a detailed physical exam, especially those parts of the neurological exam that may help to distinguish a central from a peripheral cause of spontaneous episodic vestibular syndrome. So let's consider this a bit more. What it tells us is the emergency clinician should know how to do a good neurological exam, more than just cranial nerves 2 through 12 intact, more than just extraocular muscles intact. There's the need to look for visual field cuts where there is no vision in some part of the visual field, and there need to be an exam of the extremities for cerebellar signs, including the lower extremities and the ability to have gait without a wide-based ataxic gait. What is the GRACE 3 recommendation regarding CT use for spontaneous episodic vestibular syndrome vertigo patients? The guidelines clearly state that clinicians should not use CT to distinguish between central and peripheral diagnoses in patients with spontaneous episodic vestibular syndrome. There's a moderate certainty of evidence in the published literature that says do not do a CT in these SEVS patients. Let's consider this more a bit at length. For patients with spontaneous episodic vertigo, don't get a non-contrast head CT. This plain brain CT will not detect the pathology associated with spontaneous episodic vestibular syndrome vertigo. What is the GRACE 3 recommendation regarding CTA or MRA use for spontaneous episodic vestibular syndrome vertigo patients suspected of having a TIA? If there is concern for a TIA, use CTA or MRA to diagnose large vessel pathology. There's a moderate certainty of evidence in the published literature that says do angiography to exclude large vessel disease or LVO in these spontaneous episodic vestibular syndrome patients. So when considering this recommendation, know that for spontaneous episodic vestibular syndrome patients, if a TIA is suspected, there needs to be a search for large vessel disease, which causes the majority of morbidity and mortality in patients who have a TIA and eventual stroke. CTA and MRA both can detect large vessel occlusion or LVO. We know that LVO is associated with the highest degree of morbidity and mortality, hence the need to look for it. And we know that outcomes in patients with large vessel occlusion can be improved and optimized with interventions that can occur following diagnosis using CTA or MRA. So what are the GRACE 3 summary recommendations for spontaneous episodic vestibular syndrome vertigo patients? The GRACE 3 recommendations for spontaneous episodic vestibular syndrome patients tell us the following. Use a detailed history to make this diagnosis, and if a migraine or Meniere's disease is considered, referring the patient for optimal follow-up is important. If there's a TIA considered, look for large vessel occlusion. This can occur with a CTA or an MRA of the head and neck. And do not image if there's only a low risk for TIA. In other words, if large vessel occlusion is not likely based on the history and physical exam, there's no need to do a search for large vessel occlusion when TIA may be suspected but is considered to be low risk. For more information, email me at fern.org@gmail.com. You can go to our fern.org website or find us at fern.org on our social media. We have this content posted on our YouTube channel, and it's available in the small 1-minute lectures on TikTok and Instagram. You can also find us on X, Facebook, and LinkedIn. Thank you for your participation in this educational opportunity today.